Major Depressive Disorder, Child and Adolescent Psychopathology by Lasagna Cannon. Table of Contents, Chapter 1, Introduction, Chapter 2, Risk Factors, Chapter 3, Signs and Symptoms, Chapter 4, Making the Diagnosis, Chapter 5, Treatment Options, Chapter 6, Case Study, Chapter 7, Treatment Plan, Chapter 8, Personal Observations. Chapter 1, Introduction. Introduction and Background. First, in order to diagnose major depressive disorder in children and adolescents, let alone any individual, you have to differentiate between a major depressive episode and just normal episodes of sadness or irritability. So far as development, Erickson's psychosocial stage of development, moreover, children and adolescents, of course, between the age of 10 and like 15, 16, 17, 18, something like that, they're searching for a sense of identity. And if they progress positively through that, then, that's a positive sense of identity, of course. If not, then it's identity confusion. So this stage, they're dealing with, identity exploration and search of purpose in life, so to speak. Some risk factors for major depressive disorder, and we'll talk in detail later about risk factors, but just for introduction's sake, abuse, neglect, poor peer relationships, moreover bullying, trauma, poor emotion regulation, and deficiencies in domain of competence, and also arenas of comfort. Of course, children are resilient. We all know that. And they can maneuver and navigate through the stresses of life if they have the proper help from friends, family, and community members. Now, background of the disorder. Um, can kids really be depressed? Earlier theoretical models argued that children, they don't even have the psychological processes necessary to experience depression as do adults. However, I'd like to say that, developing trends of suicidality and substance use or abuse lend at least to the idea that depression exists on a continuum in childhood and adolescence. The significance of studying the disorder, the why, the who, the how, and the what. The why involves risk factors, of course, that contribute to MDD. That's what we'll say from here on out. MDD, major depressive disorder, MDD. The who involves the people who are affected both directly and indirectly by the disorder. The how involves the many ways that MDD affects childhood development, of course, to include cognitive, social, educational, interpersonal, psychological, and emotional areas of functioning. The what involves psychotherapy, counseling techniques, and other treatment options that serves as form of intervention to both mobilize and prevent mood disorders during childhood and adolescence. Definition of terms. A few terms that need defining in order to understand major depressive disorder and in order to properly diagnose major depressive disorder: depression, psychomotor agitation, irritable, diminished, recurrent, and suicidal ideation. Depression is a mood disorder that is characterized by episodes of sadness, irritable mood, and diminished pleasure in things that used to be of interest to a person. Psychomotor agitation involves any movement that does not serve a clear purpose, such as the tapping of one's toes or pacing back and forth, tapping on a keyboard or tapping on the table or something to that nature. Irritable is a mood that involves someone becoming easily annoyed, frustrated, or angry. Something that has been diminished has been reduced or lessened. And suicidal ideation includes thoughts and plans of a person causing lethal harm to themselves. Chapter 2, Risk Factors. What causes MDD, major depressive disorder? Heredity plays an important part in the biological risk factors of depression in childhood. Having a parent with a history of depression is as much a risk factor as environmental influences. Other biological factors that influence depression during childhood include abnormal flow to the parts of the brain, imbalance between components in the prefrontal cortex, and of course the amygdala. Hormonal changes are a risk for childhood depression. There's been a link found between early hormonal changes in prepubescent females and greater stress levels, decreases in flexibility, increases in negative mood, increased risk-taking behaviors, sleep disturbances. They're all linked to childhood depression. The physiological components of temperament are linked to the development and mood orders in childhood. Children who score high in neuroticism, they're more likely to develop major depressive disorders. Perfectionism, sensitivity to loss, being diagnosed with a personality disorder, they all increase the likelihood of depression during childhood and adolescence. And of course, um, other psychological disorders increase the likelihood of development of major depressive disorder. As a matter of fact, major depressive episodes are a criteria of these disorders, and they're substance use disorders, anxiety disorders, schizophrenia. Social risk factors for developing major depressive disorder include serious illness or death of a loved one, living at or below the poverty level, maltreatment such as abuse and neglect, and insecure attachment. Parental depression or a parent living in a home who suffers from depression can also lead to a diagnosis of depression in children and adolescents. Parent depression impacts childhood psychopathology in three ways. It affects parent-child relationships, of course. It causes disruption in the familial relationships, and it negatively affects marital relationships. Another example is postpartum depression. Of course, it interferes with mother-infant emotional attachment. Chapter 3, Signs and Symptoms. What does MDD look like in children? Developmental impairment. Between the ages of 10 and 20, um, children and adolescents are searching for their sense of identity and purpose. So we're looking at Erickson's psychosocial fifth stage of psychosocial development of identity versus identity confusion. And it just simply states that, an interruption in the stage of development leads to identity confusion and feelings of guilt or hopelessness or worthlessness. Cognitive symptoms of depression interfere with different areas of a child's life. It interferes with school performance as well as peer and family relationships. But cognitively, what happens is there's a diminished higher thinking. It diminishes higher thinking. So, of course, higher thinking is needed for problem solving. This can result in poor concentration, distorted thinking, indecisiveness. It can result in a child feeling helpless, hopeless, and them being unable to devise a plan of action, of course, to defeat depression. Behavioral concerns include vocal outbursts, short tempers, of course, defiance in school, Self-critical statements, complaining a lot, excessive complaining, suicidal conversation, and risk-taking behaviors such as substance use or promiscuous sex. The emotional state of mind of a child or an adolescent with major depressive disorder is that of sadness, excessive sadness, pessimistic thinking, anger, worry, agitation. Um, Other emotional signs include hopelessness, low self esteem, guilt. Depression can even manifest as a numbing of emotion or feelings of emptiness. Social interactions are affected. They no longer participate in things that formerly interest them, and they don't hang out with, best friends anymore. So they're avoidant of social interaction. Environmental clues include neglected hygiene and appearance. Guys might stop shaving. You might smell some body odor, and hair is kind of oily looking, like it hasn't been washed. Their living spaces, whether it's lockers at school or rooms at home, they're unorganized and beyond normal, because if you have a teenager, then you know that their living spaces can be unorganized. But remember that these are all, collective together to make up together major depressive disorder. So, it's very important not to look at one thing and go, oh, my teenager might be depressed. Of course, dark and enclosed spaces. Curtains always drawn, lights off in the room, things like that. Some educational concerns regarding a child experiencing signs and symptoms of major depressive disorder would include low academic involvement, a significant drop in grades, referrals and suspensions for behaviors or truancies, and it might end in them, dropping out of school. Chapter 4, and making the diagnosis, diagnostic criteria. Testing included in diagnosing major depressive disorder in children and adolescents. The two most popular ones are the Patient Health Questionnaire for Adolescents and, of course, Beck's Children's Depression Inventory Scale. The PHQ-A is often handed, to the adolescent, so between 11 and 17, at check-in during like a visit with their primary care physician. So, the receptionist will give them this, evaluation form, and they'll go and they'll sit down and they'll fill it out by themselves, or, with minimal help from a parent. And they're doing this while they're waiting to be called back into the doctor's office, and the doctor will, go over it with them once they get back with the doctor. The CDI is also administered in non-clinical settings in schools and outpatient clinics. With a differential diagnosis, we must consider other things that, could better explain the signs and symptoms. So first, non-pathological sadness. Is this something that will, you know, is believed that's just seasonal or reasonable, so to speak? Did I lose a best friend, or did I flunk a test at school, or, did my dog die, or, whatever. Also, medical conditions, substance use. Although substance use does run comorbid with the disorder, you gotta, through evaluation and interviewing, you have to find out which came first. If it was the substance use first, then of course it's a substance use disorder. And if there is so much time between one and the other, then, it's a substance use disorder. If the substance use came second, then of course it's comorbid. Other psychologicals that have to be Other psychological disorders that have to be differentiated is, of course, bipolar 1 and 2, dysthymia, I don't know the pronunciation, premenstrual dysphoric disorder, disruptive mood dysregulation disorder, schizophrenia, schizoaffective disorder, and of course adjustment disorder with depressed mood. Chapter 4, we're making the diagnosis continue. Diagnostic criteria, of course, final diagnosis. Criteria A, signs and symptoms. What is necessary in order to diagnose? There are 9 criteria. They include depressed mood, diminished interest, weight loss or appetite changes, sleep disturbances, restless or slowed movement. That's that psychomotor agitation or retardation in movement, loss of energy, feelings of worthlessness or excessive guilt, reduced ability to think or concentrate, recurrent thoughts of death, and the recurrent thoughts of death can either be with or without plans, with or without attempts of committing suicide. Criterion B, of course, it must be clinically significant impairment in key areas of functioning. So most of the time, key areas of functioning is social, the social environment, which is like it could be in the home or the community, the work environment, and in this case, it would be school. Um, Criterion C says that the effects of medication or substance use cannot better explain the symptoms. Criterion D says that another mental disorder cannot better explain the signs and symptoms. And finally, criteria E, says that there are no manic or hypomanic episodes present. The diagnosis must specify whether it's a single occurrence or if it's recurrent. The severity is listed, and then, of course, it's followed by the presence of psychotic features or remission specifiers. Chapter 5, treatment options, therapy models, cognitive and behavioral therapy. They're both useful as multimodal therapies. Cognitive therapy it challenges thoughts and behaviors. Behavioral therapy, and they believe that behavior is respondent and operant, and behaviors are increased or decreased based on rewards or punishment. Now, the goal with cognitive behavioral therapy is to develop problem solving and coping skills in order to change, behaviors. The counselor's role is to help increase awareness of strengths and assets. So, to play up more the strengths that could help the individual. Chapter 5, treatment options, continue, therapy model. Family therapy, of course, it's individual versus the family. So, they believe more in the family versus the family as a whole and not the individual by themselves. A family in this instance does not have to be blood relatives, and they don't even have to live together. They just need to be dedicated supporters that have a long-term role in that individual's life. The goal of family therapy is to restore balance to the family structure. Then, of course, there's pharmacological therapy. Of course, in children and adolescents, the most effective pharmacological treatment is what is called SSRI, or selective serotonin reuptake inhibitors. Now, there are 2 that are most prescribed in children 8 and above, of course, Prozac or fluoxetine, and Lexapro is citalopram. Glad I said that right. And of course, there is another tofranil. It's also called imipramine. It's an antidepressant that is prescribed for children 6 years and older, normally for bedwetting purposes. Another therapy modality is interpersonal therapy. Relationships are the main focus. So, interpersonal therapy focuses, on the relationship that the child has with other people. The basic assumption is that issues with personal relationship are, of course, linked to psychological issues. The goal of this type of therapy is to help the child to better communicate with others, to be able to deal with what is contributing to the depression, and, of course, to reduce stress. Chapter 6, the case study. Carly Petrowski, aka Shandine Begay. The demographics are Carly's 15 years old. She's a female of the Navajo Native American race. She was adopted at 3 days old. She lives in a middle class home environment with her adoptive parents, their older parents in their 50s, and she attends an urban high school. The presenting problems for Carly: grades have slipped significantly from straight A's to straight F's. Truancy in school from absences. We'll talk more about that later and the specifics with that. And she suddenly quit the soccer team. She was a very good soccer player, and all of a sudden she didn't want to play anymore. And of course, she no longer communicates with friends because, for one, most of her friends were soccer players, and she's no longer involved with soccer. Developmental issues. Carly's parents report that her mother had a normal pregnancy without complication. She met all of her developmental milestones on time. She was an easygoing child. She was not exposed to trauma or abuse. And of course, Carly is halfway through what is called Erickson's identity versus identity confusion psychosocial stage of development. Of course, during this stage, she's exploring distinct roles and journeying on path to achieving a healthy identity. She's begun to ask her adoptive parents about her Native American heritage. What was her name at birth? Do they know her first name? Do they know her last name? If she could visit where she was born, it's possible that without receiving that proper support and nurturance concerning the pursuit of her identity, that she is displaying a great deal of identity confusion. Now, cognitive issues, during this stage, adolescence thinking is supposed to be more rational, conceptual, realistic. She reports having a hard time thinking and concentrating at school, and she reports feeling foggy. She also reports that school has become boring and there's no real use in the things that she is learning. And she reasoned that she would probably be more interested if there were more attention paid to issues such as global warming, racial tensions in America, war, and terrorism. The reason she gave for quitting the soccer team was evidence of the level of rationalization and conceptualization skills that she has. She reported that making the team that she had tried out for this year would put her in a better position for receiving recognition for college and recruitment and soccer scholarships. She also reasoned that since she didn't make the new team, there was no reason to, keep playing soccer. It is also important to add that an adolescent child between the age of 11 and 15 is in the formal operational stage of development. So, Piaget's formal operational stage of development. Adolescents are developing concepts of ideal circumstances, such as ideal parenting, and they begin to become more fascinated with their futures, what the future hold and what they might become. It's possible that Carly began to consider her parents' role or influence on her future as she felt, incomplete because she knew they were not her biological parents, and she wasn't really being supported in finding out who her biological parents were or are, and how, she fits in with the world. Family structure and history. Not much is said for Carly's biological parents, except that they were teenagers, Navajo Native Americans, and they had been living on a reservation in Arizona. Now, in search for knowledge regarding her parents and her ancestry, her adoptive parents, um, they pretty much gave negative answers. They had a negative view of Native Americans. They said things like they were drunk and they're lazy and poor, and she needed protection from knowing too much about them. And she told her that, she didn't need to go see them. The only thing that she would see is that they were living off the government. So far as her adoptive parents, the father works outside of the home, always have, as in copy editing. The mother works now in a busy doctor's office as a medical transcriptionist, but up until the age of 14 for Carly, the mom stayed. She was a stay-at-home mom. She has supportive parents. They support her and, you know, supported her in soccer. They went to most of her home soccer games, and, they play Scrabble every Sunday night together as a friend. Now, something noticeable about the parents something that the therapist noticed about the parents upon interview were that they were heavyset, meticulous dressers, and they kind of had a bourgeois mannerism about them. They wore their spectacles on their nose and they looked over the spectacles. So, looking down their nose upon people. Some educational issues, of course. Carly has some failing grades. She is a few weeks into her sophomore year, and she has gone from straight A's in all of her honors classes to straight F's. Now, she's missed 8 out of 41 days, but upon further review, they find that, all of these absences were in her American history class, which they both kind of had a chuckle. The advisory teacher and, of course, the mental health worker at the school, because they knew that this class was taught by a Mr. Davis, and that he had a crude and insensitive way of teaching it, as well as a boring style. There are no reported medical issues for her, no legal issues reported. The only social issues she has is, of course, her isolation from her friends. So, of course, her arenas of comfort are non-existent. As a matter of fact, they mentioned that she has only her cats that she hangs around with. She cares for them, she loves them dearly, and that's the gist of it. Primary diagnosis 29622, major depressive disorder, single episode, moderate. Her symptoms of depressed mood are diminished interest in most activities, and of course, she needs only satisfy 5 of the 9 criteria A for diagnosing MDD. Her advisory teacher reports witnessing her walk through the halls, appearing to be in a daze, not speaking to people that she normally speaks to, no longer has an interest in academics, sports, or her friends. She has a recent decrease in appetite. She reports being in a fog and having no energy to, at least the energy required to concentrate. Her scores on the CAMS, and her recent suicide attempt proves that she has current symptoms of suicidal ideation. CAMS is a collaborative assessment and management of suicidality status form that the school's mental health counselor used to question whether or not, she needed to be concerned for Carly's immediate health and safety. Since these symptoms do cause her significant distress and impairment in areas of functioning, criterion B for diagnosing MDD is satisfied. Um, with criterion C, of course, she has no reported issues, either by subjective account or observation with substance use. She doesn't have any medical conditions. So criterion D says that it's not better explained by psychotic or delusional disorder. She doesn't display those symptoms, and she must never had displayed symptoms of manic or hypomanic episode, of course, which she has not. Secondary diagnosis or comorbidity. She needs further monitoring um, for eating disorder, because she does say that she's not interested in eating, but she gives the explanation that she doesn't really like what is going what's being served or offered to her at home. It's just blah. It's not enough seasoning. It's just meat and potatoes. But even the counselor can see that she's really small. She's a size 0. She's well dressed. It seems like she spent more time on her clothing than the average child her age at her school, but she's really small. And she also gives, a reason that, she feels like I was more active before with soccer, and I'm not as active, so there's really no need to eat like I did then. So, I mean, she's reasoning, but there's still, need for further monitoring for eating disorder. Chapter 7, Treatment Plan, Major Depressive Disorder in Adolescence. Problem 1, diminished interest and lack of energy to be able to concentrate, resulting in poor school performance. The goal, of course, Carly will identify and engage in activities that will allow her to increase her energy and concentration levels so that she may increase her participation in school and improve her school performance. Objective 1, Carly will consume a balanced meal by choosing foods that satisfy the My Plate dietary guidelines for each day. The theory, the whole body is more important than the sum of its parts, holistic theory. The intervention, the counselor will assist Carly in keeping a food diary so that she may record the progress of her dietary consumption. Objective 2, Carly will engage in physical exercise daily by participating in physical movement with a group. That theory is social interaction will aid as a motivator in exercise opportunities. Social interaction is theory. Intervention, the counselor will assist Carly in keeping and monitoring her daily exercise log. Problem 2, unhealthy sense of identity originating from unanswered questions regarding biological origins. Carly will decrease episodes of worthlessness and excessive or inappropriate guilt by decreasing negative thoughts and beliefs and increasing self-esteem. Her first objective, Carly will replace negative self-evaluations with positive self-evaluation. The theory here, challenging distorted views by recognizing their effects on areas of functioning. Cognitive behavioral theory. Intervention, the therapist will encourage Carly to keep a journal of times that she elected to choose positive self-talk as opposed to negative self-talk. Objective 2, Carly will replace negative evaluations of the world with positive evaluations of the world. Of course, again, cognitive behavioral theory, challenging distorted views by recognizing their effects on areas of functioning. The counselor will role play with Carly to show, how thoughts influence behaviors and also better ways of dealing with world situations. Objective 3, Carly will replace the negative evaluations for the future with positive evaluations for the future by setting goals for herself that will align with her life's purpose. Of course, again, challenging distorted views by recognizing their effects on areas of functioning, cognitive behavioral theory. Intervention. The counselor will give Carly homework that will consist of her writing down her goals for the future and rewarding herself as she achieves them. Personal observations. My first personal observation deals with my surprise with the number of medications that were available for treating depression in childhood and adolescence compared to psychotherapy treatment options. I have to say I'm quite relieved, and I'm even more relieved because I know that this is a huge improvement from what used to be. Also, the nutrition and exercise being incorporated into therapy models for treating depression. Um, my second observation is with, of course, the risk factors and symptoms. It was almost as if the things that cause psychopathology also were as a consequence of that psychopathology. So it was kind of difficult keeping the horse before the cart. Also, the categories often, the details duplicated themselves from one category to the next. I thought it was because I was confusing myself between what was cognitive and physiological and developmental, emotional and social. Then I realized that, it was supposed to cross over as it did. Some emotional components crossed over into social components. Some social components crossed over into behavioral, and behavioral crossed over into emotional, and so on. And the treatment plans were a challenge, but the treatment plans are they're a part of this, so I'm gonna have to get it. So everybody, thanks for listening, and this was a really good class.